which is the maximum points is if over 70% of patients get an MRI before their definitive radiation course. And I'm immensely proud of these results so far this year. Is every site but one, which is within one patient of hitting that measure, is pretty remarkable, knowing where we are, or still are in many places in the country and the world in terms of baseline. Because all of the things I think you're going to talk about, I'm guessing, Tyler, might fall apart if you don't have the baseline tools to work with. So maybe we can leave you at that, as the group's proud of these results, to build on your work.
Amazing. Thank you. Super cool. And now I need to say you should send me that logo, because you'll see in one of my slides I have just a Michigan, because I'm referencing your work. But I didn't realize there was a cooler logo we should be looking at. So
I like it. We'll do it. So with that, Dr. Seibert probably needs no introduction, but a friend and colleague of mine, associate professor at University of San Diego, and radiology and urology and bioengineering. Everybody loves to collaborate with Tyler, mostly because I think he's a selfless researcher and really cares about patient-centered outcomes. And so I'll turn the floor over to you, Tyler.
thank you, Bob. Super kind. And thank you for having me. This is exciting. I mean, I always talk about how I want to do things that help, doctors everywhere, but it's not always easy to access that audience. So having you guys all here is fantastic. Some disclosures, and then, this may be unnecessary, but just indulge me for a second. We'll talk about the big picture, like why do we even need MRI? It looks like you've tackled that problem and solved it, but maybe there are some people who wonder how much it helps. The first thing is, how accurate are prostate contours on CT? And this is work coming out of your lovely state. This one may not, but the second one was anyway. So this is from Canada, actually. So this was how accurate are prostate contours? They took actual sections of human, from this visual human project. They took CTs of this cadaver that had been preserved, and then they had people, radiation oncologists, contour the prostate. And they did okay. They were in the right ballpark, but there were some significant errors. In fact, contours on average on CT were 30% larger than the true prostate. So, we're okay, too big. That might not be so bad. It seems excessive, but maybe not so bad. Except 0% of the attempts actually covered the full prostate. The median was about 84%. So we're going too big and not covering enough. So that's just a loss for patients. It's just wasted radiation dose in the wrong place and potentially missing where you need to hit. Does that matter? It could. It logically sounds like something that could matter and that you would care about. This was the Mirage trial from a Markishan at UCLA, where they compared 4 millimeters versus 2 millimeters. You can get into the details of whether the MR-Linac part mattered or anything, but for our purposes, really just if you make the millimeters of the PTV 2 more, then what they found was a difference in patient-reported outcomes in terms of side effects. So intriguing. And contouring is more accurate on MRI. So this was the pure MRI study. We had radiation oncologists. We also had some radiologists. We had some urologists. We had them contour the prostate on MRI. We didn't give them any training. We just asked for volunteers and sent to these 62 physicians a bunch of cases. And we found what this, I think, is what was most interesting to me. First of all, that the Dice coefficient was pretty darn good. And the reference here is a contour by consensus by 4 experts. It was myself and Dr. Dess, and then we had 2 really good GU radiologists to keep us honest. And we went over every single case, every millimeter for weeks. We just met every week and we went over every single one, and we did the very best we could to make it accurate. So I think the ground truth, I know Bob doesn't like that term because it's not really, but my students from engineering can't get away from it. But the best we could do, these people that volunteered were pretty close. I mean, the Dice coefficient is much better than what we see in most other studies where we ask about Dice. And even those that were still in training were pretty good. The few outliers, but they weren't too bad. And those who had been out of training for less than 5 years were just as good if people who had been out for a long time. So MRI contouring, pretty good without even much training. Even more encouraging, perhaps, though, is that we created an AI tool that outperformed the humans. Um, so that was encouraging. And I don't think I showed here the data. I didn't, but what it does matter which AI tool. So everybody likes AI and the branding is impressive because you can just use these two letters and you can get it something that sounds cool. But we did try 6 different models against this reference data set, and we found that the 2 academic models outperformed all of the commercial ones that are all FDA cleared and available and being sold. So it does matter what you use, and for what it's worth, my experience is that the bar to clear to get FDA clearance is not that high, and that we can push these companies to do better by showing them that there's room for improvement. They honestly didn't know. None of them were mad at us for showing them that they weren't doing that well. They just didn't know because they only know if the doctors tell them that it's not accurate, and they don't get that kind of feedback in a quantitative way. Then you have the urethra, which you obviously can't see at all on CT. And at least in the FLAME trial, they found that urethra dose was strongly associated with side effects. So we want to avoid it, especially if we're doing focal boost. So how well did the physicians contour the urethra? Pretty poorly, I'm afraid. So the prostate, they did really well. Urethra, the median percentage of the urethra included was 36%. 36%. The AI tool, which I had very little hope for before we made it, because I thought, how are we going to teach it well enough to do this? It turns out the bar from physicians is really low, so it wasn't that hard to beat it with AI. And we had 150 cases, and um, that had been carefully done, and it does pretty well, including on data from other imaging centers. It's not perfect. It over contours a bit, but it's conservative and it does a good job of making sure that you've mostly covered the urethra. So some progress. You can ask questions after. We'll have plenty of time for questions, I think. So, but MRI gives us more than just a great view of the prostate. I don't think there is a single area in radiology that has more high quality studies than prostate MRI, which is amazing, right? This is the thing that has the most evidence. Um, Many large studies, and it's mostly been about finding cancer for biopsy, but it's hard to look at that and not think that could be useful to us. And of course, I'm sure you've all heard of the FLAME trial that our friends in the Netherlands ran, and they compared full dose to the whole prostate, which is what we've always done for decades and decades, versus that same thing plus a focal boost as feasible. So many patients in the group that were in the focal boost group didn't actually get a focal boost. Nonetheless, there was a disease-free survival benefit, which was the primary endpoint. And also on secondary analysis of local failure patterns, or sorry, patterns of failure, they had 67% lower local recurrence in the prostate, 44% less regional or distant metastatic disease. And this was accomplished without any increase in side effects, at least as were measured by patient-reported outcomes. The patients were blinded to which arm they were on, and they couldn't tell which arm they were on in terms of side effects. So if you're talking to patients, and I present this frequently to them, I say, so there's fewer metastases, less recurrences, no increase in side effects. I don't say it saves your life. I don't think that's true. We have lots of great ways to come back and take care of prostate cancer that recurs, but none of them are that fun. And so fewer metastases, less recurrences, no increase in side effects. Literally, you will not find a patient who says, "Give me the old way." You will not find one. It makes no sense. This is basically a home run with no real downside unless you don't do it right. So everybody should get it. Are they? We did a survey and we found this is a couple years ago, but still the trial had been published for for a good handful of years at that point. And we found that even complete subspecialists, almost 40% weren't routinely offering focal boost. Generalists were overwhelmingly not offering focal boost. And then you have this great data that's much more granular than what people say they do. And we find that only 10% of patients in the state of Michigan were benefiting, at least as of 2024 paper, were benefiting from focal boost. There were reasons when we did a survey of physicians and asked, what are the reasons you're not doing it? There were quite a few that came up. But when it came down to it, one was the most critical, and that is that you can't aim at what you can't see. So this is standard prostate MRI. There are two lesions here. They're both real cancer. They're not that easy to see if you haven't been trained to do it, which none of us were trained in radiation oncology residency, I think, to do this very well, unless you graduated super recently and were with somebody who was really into it. So, like my residents, if they rotate with me, learn how to do it, I think, quite well. But that's not a guarantee even in our program because it just hasn't been part of training. So, what if we made it easier? Here's what we've developed as a quantitative biomarker, an imaging biomarker for finding cancer. And I think that it makes things easier. I'll give you a little bit of physics, but not a lot. Sorry for the physicists who are on the call. You can ask me questions afterwards. Basically, we use ADC. The radiologists use T2 and ADC. Most of the cancers, they're mostly relying on ADC, apparent diffusion coefficient. That's the most useful modality or the most useful sequence from the MRI exam in prostate for distinguishing cancer from non, especially when you're talking about higher grade versus, like a benign nodule. So that's what they're relying on. But there's an assumption here that the water molecules in the tissue are moving around freely as if they were sitting in a still glass of water. And that's not at all accurate. In fact, we've empirically derived four microcompartments. There's the water that's inside the cells, and that doesn't move much at all on the scale of an MRI. There's the water that's trying to move through the extracellular matrix, that's hindered, so there's restricted, there's hindered. Radiologists have combined these into just restricted because that's just colloquial, but that is not from a physics standpoint accurate. And the scale of movement is over an order of magnitude different. Then you have free diffusion, which is what ADC is imagining is in the body. And there is some inside the lumen of a gland, inside the urine, for example, sitting in the bladder. And then you have water molecules that are flowing through capillaries, and they're not diffusing at all, but they're definitely moving. And MRI doesn't really know the difference between those two things. So then we do some math. I won't belabor it, but we get a focus on the signal that's coming from intracellular restricted diffusion, especially signal coming from cells where there's a high nucleus to cytoplasm ratio. Because of the way the physics works, that's how it works out. And that's convenient for us because high-grade cancer tends to have high nucleus to cytoplasm ratio. This takes 2 to 3 minutes on a standard clinical scanner. Some examples. So just for fun, here are 5 patients. Take a quick look, see if you see where the cancer is. We have T2 weighted and ADC for each of these. Here's patient A, it's a PIRADS 4 lesion, there's the cancer. Patient B, there's the cancer. Patient C, just trying to make it easy. And these are all patients who did surgery, obviously, which is why we have the surgical pathology and we can see where the cancer is. PIRADS 5 lesion for the 4th one, completely blank on RSI. Why? Because there was no cancer. 2 years later, the patient had another biopsy, still couldn't find cancer. PIRADS 5 on patient E. Sorry, there's the PIRADS 5 from patient D. Here's the PIRADS 5 for patient E, also benign, and patient 5 years later had a simple prostatectomy for BPH and still had no cancer. And the nice thing about this is it's quantitative, so the number means something, whereas ADC is not very reliable at all. And I have a new study I haven't put slides in where we even just looked at if you take the same patient, you scan them on a GE scanner, and then you take them and scan them on a Siemens scanner the next day, and the ADC is all over the place. You cannot rely on it at all. Whereas this RSI restriction score is reliable, is very highly correlated, even if you go from scanner to scanner or day to day. And the number means something. If it's very high, it's probably a grade group 2 or higher cancer. And mostly it's going to be a grade group 3, 4, or 5. Whereas if it's low, it's much less likely. So this gives us, it doesn't replace radiologists, but by itself performs pretty comparably to how radiologists are doing at academic medical centers for detection of cancer prior to biopsy. And it gives you a sanity check. So when I have this in front of me for a patient, I have some sense of whether, a PIRADS 3 is believable or not, or whether I'm more concerned, especially if a biopsy wasn't done targeted, etc. And it's a lab test that maps location. So we formally tested this idea that this RSI restriction score would help radiation oncologists do a better job with targeting. It was a prospective study with 44 rad oncs. They were given prostate MR images. They were told where the tumor was in words because we get the reports, right? We're not supposed to be radiologists. We gave them in words where it was. We said, this is a PIRADS 4 lesion for this patient in the right posterior peripheral zone at the base of the gland. And then we said, it's 1.3 centimeters. Can you please contour it for focal boost? And they tried. And half the time we only gave them conventional MRI, and half the time we did give them also the RSI-RS maps. No training, no explanation except, hey, this is a thing that we made that helps, find cancer. And here's how they did. Here's an example patient. Red is what they were supposed to target, according to the two radiologists who in consensus drew the target for us. And on a different day, they didn't know they saw the same cases. We had them like 2 months later, we had them go over new cases, but mixed in, we included cases they had seen before. Sometimes they had seen RSI first, sometimes they saw conventional first. Either way, it didn't matter. They didn't get better 2 months later. The performance was about the same, and they were better when they had the RSI-RS. Here's another example where they were supposed to hit and then what they did hit. So I asked my team to look at how many complete misses, because it's hard to quantify how much better. What if you're like a little bit close? Is that good enough or whatever? But if you didn't even have a single voxel of the true target in your contour, that can't be good. So it turned out it was about 18% on conventional imaging overall. And the median, because then I said, fine, there were a couple of people who were really bad, but everybody can't be that bad. And that's true. There were a couple of people who almost half the time completely missed the tumor. Um, but the median was 14%. So even, the typical RADONC participant was 14% of the time completely missing the tumor. When we give them RSI-RS, the median is 0. It doesn't mean there were 0 misses, but most people are right there on 0%. And the people who were doing really poorly at first with no training were suddenly much more accurate. Does it matter? It could. It depends. If you can't boost that patient anyway because it's too close to the rectum, for example, then that wouldn't matter. But you can boost most patients. Here's an example patient, patient 3 from the study where we actually planned. We did a new boost plan on every contour. So like each participant's contours. We had 44 participants contours. We had 44 different plans. If you use the expert plan, well, 45, because we also had the expert radiologist. If you use the experts one for this one, the probability of recurrence in the first 5 years, according to the FLAME model, we got the model from them, collaborated with them on this. It was about 4%, because you get a very high boost for this patient. But most of the radiation oncologists are giving us contours that generate plans with an 18 to 19% recurrence. I mean, for this patient, it matters as much as ADT. I mean, I'm almost embarrassed to say that because it sounds so ambitious, but really, if you have a target that you can really hit, then not hitting it is a big problem. So what does this mean for patients today? We can do safe, effective, precise therapy. We can reduce recurrence. We can even reduce metastasis if you count regional and distant together on the FLAME trial, which I think is reasonable. So what's the catch? Well, for one, you found everything on MRI. Now you have to get it onto CT for planning. You can do MR only SIM, which we've recently implemented here at UCSD, but it can't be done for all of even our patients. And we just implemented this recently, and it took a lot of effort. And I direct an imaging center here, so we had access to a scanner, et cetera. So realistically, most of us need to be able to get the prostate from the MRI onto the CT. And it's the prostate that matters, not the bones, not the obturator muscle. It's do you get the prostate lined up so that you can get the urethra and the GTV in the right place. So we created a tool that does this in an automated way. It's AI and also pre-AI thinking. So what we do is basically you take the CT from your patient and you register that CT to an atlas that's like an average of lots of patients so that you can find where the prostate is. And then you do the MRI, the same thing. You take the patient's MRI and you register it to an atlas of an average prostate MRI. Then you line up the two, you know where those now line up because the atlases have been registered very carefully to each other. And then you have an automated prostate contour from the MRI that you can overlay on the CT, which is, this showing you that you can get it in the right place. Then it lines up like this. This is what I actually use for registration at this point. I move this MRI contour because that is what the prostate looks like in this patient. I move it onto the prostate on the CT. And sometimes I will get pushback from the therapist or the physicist or other physicians, and they say, well, awfully, it doesn't look right, Tyler. It looks like, there's more prostate that you didn't include. And that's when I have to show them the MRI. I say, that's not right. That wasn't actually prostate up there. Don't worry. We can see it very well on MRI, and then we can line it up on CT, and it helps us to understand what we're seeing on CT. And once we have that, then if you've seen the urethra on MRI, you can also put it on the CT and use it for planning. To test how well our automated registration tool works, we needed a ground truth. There isn't one. How do you decide that? I was thinking about this problem for probably like 2 years. Like, how do we see if it works? We make something and we're working on this tool, and how do we even know if it's working other than like Tyler said it works? That's not good. So we had 6 physicians. Here's what we did. 6 physicians, all academic subspecialists in prostate that use MRI a lot. And we would have 3 of them go over a bunch of cases and the other 3, so with 2 different groups, 1 month washout period, repeat. Sometimes they saw the same cases again. Sometimes it was a new set of cases. And we figured if I or Bob from 1 month to the next we register this exactly the same, that's pretty believable. If he and I within ourselves registered exactly the same, and then between each other, we also registered the same way, that would be very convincing. And any variation beyond that is basically what you can't be sure of. And so if our automated tool gets us within the window or the like cloud of possibilities that 6 academic physicians that only really treat prostate could do, then that's as good as we can do. I hope that makes some sense. Here's what we found. There was more variation than I would have liked. Sometimes there were some outliers that were even over a centimeter off or a centimeter and a half from the other people. Maybe they were the one who was right. There's no way to know. We took as the consensus, and again, I forgot, I didn't catch this one, but one of my PhD engineering students called it the ground truth. It's really just the consensus across the 6 physicians, 3 in each case. What you find is that between physicians, there's a fair amount of variation. This is now when you use the Precision Pro automated tool, it brings it down a little bit, but you still see some variation. The Precision Pro tool by itself, though, is well within the range of even intra-physician. So this is just 1 month apart. And I want to emphasize that this is how well the physician registered the MRI to the CT of the prostate, where they thought it was good enough for them to be able to do, focal boost and urethra and everything. So, I'm not going to argue that this is acceptable variation, but a couple of millimeters is less than a slice of MRI. So, it's probably close enough. And we all know our gradients aren't that great. So it's not like we really have millimeter precision. The prostate moves a few millimeters during treatment. This is actually reasonable. And the automated tool is getting you very close. We do adjust it. I mean, I was showing you, like I will get it, and about half the time I don't adjust at all. And about half the time I move it a few millimeters because I think that it's improved a little bit that way. So that's our MRI CT registration. Last thing, just kind of a sneak peek into what we're thinking is in the future. Take it with a grain of salt, but we're running a randomized trial now here at San Diego where we're comparing, what should I tell you, flame. I don't know if you saw this paper. This one came out just more recently, but they did an analysis to see where in the prostate there was a recurrence in the patients who had a recurrence. Fortunately, local recurrence was quite rare, only 5% overall in this paper, much higher in the standard arm than in the focal boost arm, which is the point of the flame approach. 24 of the 28 local recurrences, intraprostatic recurrences, they had imaging from before and imaging at the time of recurrence to determine the location of that recurrence. 23 of the 24, it was in the original GTV. So the recurrence was happening where the tumor was visible before. It's not really happening in the rest of the prostate. There was one patient who had a distant within prostate only recurrence, and it was in the anterior fibromuscular stroma, which is a strange place to see prostate cancer. I think it was visible before treatment, but it was hard to make that call before treatment. And I think now with maybe with RSI and then also with PSMA PET, I think we would have found that, but it is pretty rare. So one fluke out of 571 patients, but very encouraging. So most recurrences are going to be outside the prostate, and the ones that are in the prostate happen in patients who didn't get a focal boost. And regardless of whether they had focal boost or not, it mostly happens where you saw the cancer in the first place. So this is standard radiotherapy. 70 gray. This is a 28 fraction or 5 fraction dosing that we're using, and you can boost it. You add a PTV margin around the prostate. Here's our tumor-focused radiotherapy that we're doing on the trial. We do the same boost as we would have before on the GTV. We add a 5 millimeter margin within the prostate and say, make sure that gets full dose, what would have been the standard dose before. And then the rest, lower it. Lower everything else, the PTV and the rest of the prostate to 56 and 28 or 30 and 5, and see if we can reduce side effects while maintaining the same cure rate. The plans look amazing, super great. You always feel great that we've avoided any violation of constraints or goals for planning. And we're seeing how the patients do. They're blinded, so they don't know which arm they're in, and we're asking them for feedback on side effects through formal questionnaires periodically. And then we'll follow them to make sure that we're not seeing a lot more recurrences or something. So again, plans look really good. Focal boost versus tumor-focused radiotherapy. I argue that if we had had MRI when we first invented radiation for prostate cancer, we would probably be doing this as the standard. We wouldn't have assumed that you need to give the full dose to the entire prostate. So now it's time to find out if that would have been a better way to go. And I'll conclude with just basically, we're trying to make technologies that help all the doctors, you all, and all of your colleagues to deliver the best possible treatment to patients everywhere. And I think that we can leverage technology to do this much faster than with just trying to educate generations alone. I mean, the effort for like focal boost and urethra to educate all of the educators so that we can then educate all of our residents, that's going to take a lot of time. I think we can do better. I think we can do it faster. And I'm excited about the idea of seeing if we can test some of this in real practice with you all. I'll stop there and stop sharing and see if anybody has questions.
Thank
Hey,
you so
Tyler.
much. This is Nitin Vaishampayan from Karmanos in Detroit. I'm a radiation oncologist. So I was wondering the timing of when the MRI is done prior to treatment. I mean, are these MRIs done essentially at the time of when simulation is done, or are you using an MRI that was done maybe a month before the patient starts treatment?
Great. So there's what I'm doing and there's what I think would be reasonable. I think that the prostate MRI doesn't change very much over even a few months. So my rule of thumb is 3 months, which I think is pretty conservative. I think 6 months would be fine for the vast majority of patients. Then there's what do I do? Well, I'm always trying to do new things. And whenever I've got this rad target trial, my patient had an MRI outside, but then I'm putting them on this trial. So what I do is I get a new MRI and I'm doing MRI only sim. But
I,
that's
I see.
this year. If you had asked me 2 years ago, it would have been a different answer.
So the concern that I potentially have is using an MRI that's 3 months old, 2 months old, 1 month old. It's not uncommon that we do spacers nowadays. And
Right.
the MRI probably didn't have a spacer at 3 months before the treatment. So now everything gets pushed. When a spacer is
Yeah.
given, the anatomy, the prostate gets indented sometimes, there's drooping over. So I would find it very difficult to, again, fuse the MRI on your CT after a spacer is put in. And that could very much limit a lot of things when you're trying to be so precise with localization and giving boosts like that.
Yeah, that's a good point.
And the field has really gone towards spacers, right?
Yeah, I'll give some point counterpoint, I suppose. Number one, the data for spacers is kind of weak. So we do it, and I do it, not for everybody, but it's pretty weak. So it's like when Allison Tree tells me, we're great friends, but she'll say, "Well, Tyler, I don't know if you need to do focal boost once you do SBRT." I said, "Well, your PACE B trial didn't prove that, Allison, right? It just proved that it was the same as conventional. It didn't prove it was better." So you can either extrapolate and do focal boost with SBRT, which I do, or you can say there's not enough data for that. But if you do, then are you going to tell your patients I'm giving you inferior potentially treatment because it's faster or not? So sometimes, it's the same thing with the spacer. It's like you have some evidence that it lowers diarrhea and bowel irritation. It's valid. I think it's fine. I would do it for myself. But for a 75-year-old, I'm like, I don't know. I mean, the risk of infection and everything, long-term risk of bleeding, we don't even know if it reduces it. So I'm not trying to talk you out of spacers. I'm just saying that if I had to choose between focal boost and spacer, I would take focal boost. It has phase 3 randomized data to support it. If I don't have to choose, which I don't, I just order a new MRI after I place the spacer. You can say that's expensive or inconvenient for the patient, but again, then how much do you care about that spacer? And how much do you care about focal boost? And how much do you care about making sure that you get the contours of the prostate accurate? So if none of those things matter, then you can do whatever you want. But if you care about all of them, then you kind of have to choose, where you're going to put your money and your time. You can use the old MRI for focal boost with the spacer. I'm not convinced that you can't. I'm just saying that it's a valid concern to bring up. I would just use it. Except like I said, what I actually do is order a new MRI because I have a protocol for prostate radiotherapy. It's shorter. I have them do a full bladder until I get rid of full bladders with my other trial. It's another topic for another conversation.
Tyler,
Tyler,
sorry, go
go
ahead.
ahead.
No, I was going to ask, are you repeating a 3T for your
Yeah.
treatment planning MR?
Yes, I don't think that's necessary per se. We don't have great evidence yet. We have a few collaborators in the Europe and in the US that are trying to do it on like their department 1.5T MR sim. So we'll see how it goes. I think for the anatomy, totally fine. 1.5, not an issue whatsoever. For the RSI part, for like the focal boost and optimizing that, I don't know yet. I think that a good new modern 1.5 would be fine. The gradient performance is more important than the magnet strength, the field strength, static field strength. but we don't really know. So to answer your question of what am I doing? We don't really have access to good 1.5 Tesla here, so everything's 3T, so I don't even really have a choice. You do worry
Okay.
sometimes about distortion. I didn't put slides in about that, but we have a paper that we're putting together. We have a presentation at Astro. We solved this problem for the most part. We do much better than what is currently being done on most scanners with our correction algorithm. Um, so we solved it a while ago, but getting it published is kind of a pain. Physics stuff, it's like the MRCT registration thing. Getting that published was such a pain because it's like it's not that interesting of an issue, but it's a practical issue. And sometimes there's a disconnect between like what people actually need to get the job done and what the reviewers are thinking about because they send it to someone like that's a physicist and I mean honestly if you send it to me it's like if I weren't thinking about how do I get this to the people, I could be thinking this is not very technically interesting. So anyway, some of the answers. 1.5, totally fine for anatomy, sounds great. If you're talking about lesion detection, you might want to register to your 3T that was done before. If one was done, that would solve that problem. And if you want to do RSI, jury's out.
Hey, Tyler.
Simile, you had a question?
Yeah. I don't know if we've talked in person ever, Tyler. No.
No, just online. Nice to see you.
Yeah, thanks for doing this. This is really helpful. I really appreciate it because we're within the practice, we're trying to sort this out as well. So, Nitin, I'm kind of piggybacking on his question. Is there any other instructions to give for the MRI? Because it is part of a sim, and we've been just saying MP-MRI and,
Yeah.
but do you
Well,
see anything else?
I think that this is it. I think that we should, as a field, adopt the practice of having like this is what we want for radiation planning MRI and give this to all of the imaging centers that we work with. That's a big ask, perhaps. Maybe it needs to be done at an organizational level, and maybe you guys can do it in Michigan because you can kind of have a thing that you say to everybody. Um, our take has been because we're doing this RSI part as well, is we basically just tell people this is your protocol, do this,
Yeah.
and which I'm happy to help with you guys too. It gets messy because there's so many different scanners, but also because the radiologists at each center feel a lot of ownership. So it
Hmm.
kind of depends on what you're doing. So what we've done here, for what it's worth with the radiologist, is for the prostate radiotherapy scan, I took out the contrast. It's not helpful for like almost ever
Okay.
and it takes time and it's another thing and it's a needle and right.
Okay.
And it's more expensive, a lot more, which is why a lot of centers don't want to give it up. Um, so we get rid of the contrast. They tell me it needs to be fast. We do full bladder because that's how we treat. Again, I don't know if I believe that, but it's the standard right now. So we're doing a randomized trial comparing full or empty, and right now it is what it is. So we do full, and it needs to be short so that they're not going to, be really uncomfortable on the table. Empty rectum, same instructions that we give for sim, but we're not doing this in radonc department. We're doing it at radiology. So
Yeah.
we just gave them a protocol. Like, here's what we want. We want the T2. Don't care about all of the planes really. We just want axial. I used to do sagittal as well. I don't think it's that helpful, but it used to, whatever. So I like what I really care about is axial. If you must do another plane, just do one other one. Don't do two more because it takes more time. Um, and then get the diffusion right, which for us is RSI, but you could do conventional diffusion,
How
and
do you
that's
just,
it.
is RSA like anyone has that sequence available?
If you email me. So it was invented at UCSD by a friend of mine. There is a patent from the university, but from an academic standpoint and collaboration, and I consider this an opportunity for collaboration with MROC. So if you guys want to pursue that too, we can do that, and we'll have to talk to your imaging center partners. And so it probably needs to be like your favorite imaging center, not like everybody in your community
Yeah.
at each place, but like, can we install this, put it in? The implementation of the protocol is pretty easy. Any physicist at a regular imaging center should be able to do it. The processing after the fact to get the images to look pretty, they wouldn't have. But it is possible for us to, for example, put a software package at your MROC central location that would then make it so you could send your images, your DICOMs your MRI and your CT. And our software would, if you have RSI, do the RSI part and give you those maps out. And whether or not you have RSI, you do the automated contour of the prostate, automated contour of the urethra, and automated registration, at least initial registration of the prostate, and send it all back to you. And then you use it. And if we do this, which I'm all for, I would just request that we have like a plan for measuring how did it work, like if it's garbage, tell me it's garbage,
Yeah,
formally.
yeah.
Like let's figure this out so that we can make things better. If it's working really well, that's obviously good too. Um, like I said, there is a patent on the RSI bit itself, but that's not a barrier to collaboration. There's a local startup company in San Diego that I do some consulting with, so I do have a conflict of interest. It's not very big. I don't care that much, but they sell it mostly to radiologists. They haven't done
Okay.
anything really with Radonc. They kind of want to, but they don't have the other parts, the registration. They don't have the distortion correction. They don't have the automated segmentation as good. They don't have noise correction as
Yeah.
good. So their RSI, everything about it is like not quite as good
Okay.
as our academic software, which we're trying to get into a commercial, but that takes a long time and I'm not a business person. So I think someday, and maybe this would help, but really I just want things to help people.
Yeah. And sorry, just one more thing, like clinical. So I'm trying to do this at our clinic. I've done 4 cases. My practice is very, very breaky heavy. And so that, there's just a difference in mindset about this. But
Sure.
one thing that's come up, we kind of had a bigger discussion about it. And the pictures you showed where the PIRADS 5 didn't show any cancer on the specimen, and that line came up with a few of our prostate guys. It's like, I don't even trust the MRI actually showing me where cancer is, and then you want to boost that. And I kind of don't have a way
Yeah.
around that argument.
Yeah. So, I mean, the flame study is great. I think is really nice. You have to take into account that they had expert radiologists that were helping with the identifying the lesion. That's one thing. Um, Also, though, it was old MRI. The studies was done a long time ago. We're looking at 10-year outcomes have been published, right? So the MRI was older, and the expertise of your average GU radiologist, I think, has gone up because now it's very standard practice for them to learn how to do prostate MRI well. It's a huge part of radiology. So I think that average radiology expertise has gone up. Then there's another thing. I don't know how many of you have ever gone to watch a biopsy, but a lot of times when they miss, sorry, a lot of times when the PIRADS 5 is negative, it's because they missed. And so if you see, I see this all the time, even with, like my great colleagues here who are doing fusion biopsy and whatever, they'll have a PIRADS 4 lesion. It looks really bright on RSI. It looks
Yeah.
bad on ADC, whatever. And then they don't find cancer there, but then they'll find it nearby. And you need to be broad there.
Yeah.
Like the difference between apex and mid on radio, they're not even using the same angle, right? The radiologists are using horizontal axial slices and calling thirds, and the urologist is looking at it from the rectum. So they're looking at it like this. So they'll be like, "Oh, I found this in the apex." And you're looking at like that's definitely mid gland, right?
Oh,
So
got
like
it, because
this.
of the angle.
But
I got
so
a really machine. I'm sorry, but
it's all right. But I mean,
okay.
basically, I think that you can trust the MRI more than you can trust the biopsy. Not for whether there's cancer or not, absolutely not. But for location, the MRI is more accurate than the biopsy is, the needles description.
Amazing. So this ties perfectly with my question. Madam Mussolini, I'm a radiation oncologist in Kalamazoo. Do you limit the boost to certain pathologic grades, or is it just based on imaging criteria? And
Good
also,
question.
how do you reconcile when there's discordance between path and imaging? And I get your right mid versus right apex. I get that all the time, and I think it's probably the lesion that they missed. But sometimes it's left base and right mid, and I don't
Yeah.
know that they necessarily missed that far. And if there's a grade 4 cancer in the PIRADS 5 lesion, and then there's also grade 4 cancer on the opposite side of the prostate, but on imaging, it's only on one side. Do I boost both? Do I boost one? Do I not boost at all? And should we even be doing boost in if we don't have RSI, which I'm guessing the answer is yes, since the Flame study is now 10 years old. But,
Right.
but
Yeah, exactly. Flame didn't have RSI. You don't need RSI. RSI just makes it easier, right? But you do need somebody who can look at the MRI and find it. So if you have PI-RADS and you can get the radiologist, the other thing I asked the radiologist to do on the prostate radiotherapy one is contour the lesion. Show me where it is. At least put some arrows on it, you know? So we do ask for that. And I tell them, you're allowed to say, I don't care if you put in your report that this was an abbreviated exam, therefore I can't give an official PI-RADS. And I said, so you're getting an out. You're not even responsible. The liability is gone because you can just complain that made you do a bad study. I didn't, is fine, but like bad. But now with that time that I saved you, can you please circle the tumor? And they've responded well to that. They do it for the urologist. Why don't they do it for us? You know? But I think so. Two things. One is, should you still boost? Yes, because at the end of the day, Flame showed you that it didn't show you where all the needles were. What it showed you is that the cancer was better controlled if you boosted the thing that was positive on MRI, and that if it recurred in the thing that was visible on MRI. So what happens with that other stuff? I don't know. The patient you described, would I put them on rad target? No. Because I mean, if there's grade 4 disease on the other side and we can't see anything, I'm not going to lower the dose there. But that's pretty rare. Whereas, like, I had a patient who had there's a right apex lesion, and it was on MRI, and it was benign on targeted biopsy, and the right apex was benign on systematic, and the left apex was positive with high-grade disease on systematic. So we sent for a new targeted, still came back that way, got a PET for staging. The PET was positive in exactly the same part as the MRI. So I put him on rat target. There's no way that the guy has a blazing lesion that's that's benign, and it happens to be right next to a really high grade disease. There's just no way, right? You're not going to have like a false positive and a false negative right next to each other. The imaging is what's anatomically accurate. So I would still boost what you can see. In terms of your question of what grades do you boost, it matters most for high grade disease. That was shown very nicely in the post hoc analysis in Flame. It makes sense. PACE had no focal boost and everybody was fine. At least half of the patients on PACE B didn't need treatment. They could have had active surveillance. We know that from the new analysis of PROTECT. Most of these patients with grade group 2 disease would be fine without treatment if they don't have cribriform or intraductal. So do you need to boost them? No. If you can see it and it's easy to do, can you? I do, because why not? But I try to get them on active surveillance first. But I don't care that much whether you do it. Once you get to grade group 3 and especially 4 and 5, and if it's not the whole prostate, then I think it's a disservice to the patient to not boost.
Maybe I'll make an observation in a couple of minutes and certainly can leave you with the last word if you want, Tyler. Just a couple of reminders. One, for the group right now, thanks to Carolyn and others, we're actively have the registration tool and the auto contouring prostate tool within the MROC infrastructure. And so we're piloting some MRIs being uploaded and seeing how that works. And so that's on the back end of how these tools work in treated patients. But you can imagine where we can work towards moving that forward in patient care or improving quality even retrospectively. And then also just a more global observation is that this is the area that MROC excels, right? Our starting point is 3/4 of the centers not doing it and 10% people of getting it. And there's a lot of challenges with registration and biopsy and discordance between PET and MRI and distortion with spacer. But there's also a lot of data that suggests the benefits in doing it in a world 10 years ago where, and PI-RADS didn't even exist when the study, in the original Flame study, and still seemed to work with no PTV margin within the targeted volume. And so, can we do this as a group, and what are the appropriate stages to do? We always know in MROC, you don't boost everybody. I mean, you shouldn't. You should never set 100%. Heck, you might even start well below 50%. But there are people that we know that are super well lateralized It's positive on the biopsy. It's positive. You don't need RSI. You just take one eye and look at it at T2. The biopsy's there. Those are the type of patients where maybe we can all develop a little bit more confidence in identifying that. And then we didn't even get, Tyler, maybe we'll leave you with this. What is the right boost dose? And what is the right boost dose in which fractionation? And is there an upper ceiling to that benefit too, right?
Yep. Yeah, and we're never honestly going to have randomized trials for all of those questions, right? It's just too hard, and like what's your endpoint takes too much time. So we'll have to extrapolate some of it. But like you said, you go back to the basics. Like there are lots of caveats and lots of, but for some patients, it matters a lot and it's very doable. And even if you aren't boosting, making sure that you like the urethra might still be helpful. I'm not totally convinced, to be honest, but for now we're trying to avoid it. Can't be bad to avoid it. And getting the prostate right still matters. Going back to the CT, like if you're getting an MRI and you're using it to make sure that you know the patient has cancer, that's awesome. If you're not using that MRI to make sure that your contours are as accurate as possible, if the registration is still a barrier, then those are things that we can improve on, and they'll, it's a lot cheaper than an MR Linac. It's like, you can get a long way with the technology that's sitting right in front of us. And I love the RSI, but do I think that you absolutely need it? No, like I said, and Bob said, for some, it's really easy to see where it is.
Well, on behalf of everybody, thank you, Tyler, for all of the work that you've done. I genuinely think that in the last 5 years, we've made a big difference in the lives of patients in the state of Michigan and beyond. Our boost paper made it into the plenary session of Astro and things that we're proud of. But certainly, we tend not to stop where we're at or be satisfied for where we've gotten to. And thank you for sort of helping us see where we might be going in the future.
Awesome. Thank you so much. And I leave it to you guys. You got so much to figure out and lots of things to think about for your next metrics. But if any of the stuff I talked about could be useful, I'm absolutely happy to collaborate and figure out how we can make radiation more precise, more safe, and more effective for patients with prostate cancer.
Yeah, thank you so much for your time. This was really helpful.
Thank you.
See you guys in July. Is that what the message is, Melissa? All right.
Yep, July.
All right. See you later.
Bye.
Bye, everyone.